I'm Marta Petersen. I'm the director of the Utah Telehealth Network. I'm also a dermatologist at the University of Utah and do dermatology with the prison.
I'm Jeffrey Saffle. I'm the medical director of the telemedicine program at University Hospital, and you've already heard me.
And you've heard me as well, Allan Okrainec from the University of Toronto. I'm a laparoscopic surgeon and director of our telesimulation center in Toronto.
And again, I'm Wesley Valdes, and I'm supposed to ask stimulating difficult questions of the panel members. But in light of, again, of the topic that's in discussion, one of the things that Intermountain is working with the individuals here as well is to come up with very affordable solutions for telemedicine. And one of the questions that I wanted to ask is, with the consumer-grade technology that is coming out at higher and higher levels of quality, do you see a role of those types of technologies, by that I mean the stuff that you could buy at Best Buy and those kinds of things, as playing a role in telemedicine as opposed to the traditionally very expensive high-end versions of those things, which we all enjoy, but in many situations might be unaffordable? And Marta, if you wouldn't mind?
Sure. Well, we've had a lot of discussions throughout the afternoon about the use of cell phone technologies and the mobile technologies into the home, and I think it's obviously going to play a big role. There are still challenges, especially when you look at some of the iPad type mobile technologies with bandwidth, still in the developing world. I think we've all seen that. You look at the 3G technology with the iPhones or with the cell phones, and you get a much more robust, or it's much more available in the developing world, as we've heard today. So I think that will particularly be very helpful as we go forward and look at dispensing this, especially to provider to provider, the way you guys were talking about. I think that'll be particularly helpful.
Well, if I could ask, expand specifically from the idea of dermatology, have you been getting any either store and forward or real time using either the webcams or the iPads and things like that?
Oh yes, yes. Now, I mean, we don't have a formal program for that, but I have patients sending me pictures quite frequently. And I deal with a lot of leg ulcers, so they're really gnarly pictures. I don't open them up in public, but yeah.
And have you been seeing the quality of those getting to the point where they're acceptable, or?
Well, you know, I think the quality certainly can be very acceptable, but it would require some training. Having the patient take their own photo of their leg generally leads to a poor quality image. But certainly with a little bit of training, the iPhone camera is great. I mean, you can get resolution you can't get on a lot of digital cameras.
So in this, kind of heading in the right direction. Mm-hmm. Excellent. Jeff, any thoughts?
Well, I agree that the technology is soon to be ubiquitous, and I was very interested to hear people at this conference say that there are now many areas of the world that have cell phone access that don't have electricity. So I think that's going to make this communication much more available. What it will do, in all likelihood, is make low-quality video available to all of us, which will help demonstrate the limitations of low-quality video. It will make high-quality store and forward images available to us, but I think more importantly than anything else is that it's going to make the internet available so that the video downloads, the webinars, the websites, the instructional material that really is a major component of the medical home is really going to assume a much more prominent role. And video use, which everybody perceives as telemedicine and which is very appeals to the imagination, it's going to become less important, and we're going to start using these other modalities more.
Excellent. And for a long time, before HD video was even available, I mean, telemedicine was being done on standard definition video for quite some time. So I think we kind of sometimes have the current line of thinking that it has to be Blu-ray quality XXX. That was probably a bad reference. But
that does look good on Blu-ray, though.
But certainly the consumer-grade technology is, probably surpassed what people had been doing telemedicine on for quite some years. Now, in your world, does that seem to hold true, or do you see any other?
I mean, absolutely. I think I would agree with all the comments made so far. Certainly, you heard in my own presentation, everything that we've been doing has been using consumer-grade technology. I think regular laptops. I think in one of the comments that I hear the most when people see us doing telementoring over Skype and they compare it to perhaps some of the more expensive solutions out there that we commonly use, is just how reliable it is, how good the quality is. and how easy it is to set up. I think if we look back at our own environments and within our own hospitals, I think it is unavoidable that the end users and the clinicians are using these devices every day. And I can certainly speak for my own institution, where for many years they would try to say, well, you know, you can only check your email on a BlackBerry device using the enterprise server. Well, the reality is, you know, many people purchased iPhones, and people will work around things and check their emails with their devices. So I think our institutions need to adapt and realize that, you know, they need to use the devices that we want to use and adapt them to make them secure and safe for our patients.
Excellent. One of the other questions I was interested in is there's a lot of store and forward use in telemedicine, as Marta just referenced and things. But given the topic of surgical support, what role do you see of asynchronous types of services to, if any, to support a surgical type process?
The surgeons take that.
Okay, well, you know, I think asynchronous transmission has kind of been overshadowed by video, and video is so emotionally appealing and so immediate that everybody has gone to that almost exclusively. I think, again, that the big trend we're going to see in the future is to realize that video has substantial limitations. The bandwidth is a problem. The access to an expert is a problem. One of the places we see that is in mental health in Utah. Yes, video makes mental health services available to people in rural areas, but if we had every psychiatrist in Utah on TV 24 hours a day, they still couldn't begin to fulfill the need for mental health services that we have in the state, and obviously in the third world it's much worse. I think what asynchronous technology is going to do, again, is bring us back to the idea of utilizing all of the other resources that are available for health information on the internet and elsewhere. Radiology is now all asynchronous store and forward. I think in the future, pathology will all be asynchronous store and forward. There's a great deal that can be done with diagnosis, even in surgical disease in that regard, and I think you're going to see that used more and more.
And you mentioned earlier the prospect of using this type of for training as well. So asynchronous could be a video that's sent, but you could do training through like surgical training for techniques or debridements or a certain procedure, I'm assuming, through that as well.
I mean, you know, I would say our residents now more than ever, the first thing they do when they're preparing for a case the next day is they go online. You can find any procedure on YouTube. And there's nothing, you know, more consumer grade than that, going back to that. But you can go to WebSurge, you can go to Sage's TV. So I think you're right. We often think of, you know, video as video, but it is also asynchronous. And even in terms of looking after patients, that is certainly something that we video the vast majority of our cases. And so if you can't get a consult intraoperatively in that moment, you can take that video, edit a 10-second clip. I can send it to my hepatobiliary colleagues and say, hey, this is what I saw, you know, what do you think? Or, you know, we had this complication, you know, what should we do now? So I think there absolutely is going to be a role.
Fantastic. Now, usually when I'm a moderator, there's often questions that the audience would like to ask of the panel, so I do want to take a second and see if there's any. Sure.
Can I come right here? Is this one on? Hello? You can come ask your questions here. We're trying to record that as well.
Oh, sorry to surprise you on that one.
We're talking about medical legal aspects of telemedicine. If you're asking for a consult from a colleague in another state or another country, all these things I think need to be worked out. I don't know what your liability will be, and what are the thoughts on that?
Well, a couple of comments. First of all, liability is an often cited reason for people to be reluctant to go into telemedicine. There is not much case law about telemedicine. The few suits that have evolved have mostly surrounded prescribing practices. So whether or not you need to have a personal relationship with the patient, whether you need to have a physical examination of the patient before you prescribe. There have actually been a couple of lawsuits against institutions because they did not make telemedicine services available. But specifically in regard to the issue that you cite, if you call me for a consult and I do not see the patient, there is no doctor-patient relationship. The patient can't sue me. You can sue me for giving you bad advice, but it's just advice, and you're the practitioner who's going to carry it out. So from that standpoint, you're relatively protected. I wouldn't say you're absolutely protected, because this is America and anybody can sue anybody, but I don't think the risks are great.
Yeah, I mean, I would agree with that. And I think you're absolutely right that it's one of the most common things that is cited for not doing telemedicine. And within our own country, we tend to do it within the same province, and so obviously you're protected that way. And I think all the comments that you made, I think lawsuits in that realm are very, very infrequent or have not happened. So,
Marta, do you have anything?
Well, I think that, yes, I agree totally that I think the liability issues can be mitigated by having a practitioner on the other end. We talk a lot now about privacy and security when it relates to telemedicine, which is another huge can of worms. You have these consumer-grade technology like Skype and FaceTime, which is not encrypted. So you're kind of, if you're doing protected health information over non-encrypted, you have to at least disclose that. I mean, the likelihood is that it's not going to get intercepted, but email isn't necessarily encrypted when you receive some question from a patient into your email box either. And so it's just a very complex issue, and I think the key is to look at them and then disclose to the patient so they know what they're getting into.
The only thing I would add is you mentioned other countries as well, so it would be prudent to be aware of the international laws that do apply or any local laws if you are doing it in another country. I mean, it's always something you should look into as any due diligence of any aspect of medicine, so I would just agree on that.
I just have one more comment, and that is that I know our hospital is much, much more concerned about HIPAA violations within the hospital, abuses of the electronic medical record, than they are about telemedicine. And that's where I think American surgeons really need to be concerned. It's really their own practice that they need to be worried about, not these international connections.
I think I saw another hand.
Hi, I'm Tarek. I'm from the United Kingdom. I'd just like to say your talk about telementoring was extremely inspiring. And I think I'm a first-year resident back in the UK, I think it applies not just in developing countries, but all over the world, this concept of telementoring and practicing yourself as a surgeon with reduced working hours all over Europe. One question I had was, when you come to actually do your telementoring and the teaching, do you think there's going to be a difference in this type of syllabus that you deliver or the type of training the pace? Is it going to be different to the way you would deliver it if it was just person to person? When it's telementoring, how do you adapt yourself to that?
That's a great question, and I actually think that's one of the advantages of the telementoring way of teaching, is that our brains can only absorb so much in a fixed amount of time, and so by distributing it over time, it does forces you to really, to drag it out over a longer period of time. And we're seeing, and there's good evidence for this in the literature, that people absorb more, they learn more, and they retain more long term when you can distribute that. So you do need to modify your curriculum, but I think that's a positive.
I have another comment. I was also delighted at the telementoring information that was presented. I think there is a great deal to be said for having a second set of eyes that are not emotionally attached to the patient or to the operation, and that's one of the data that is emerging from these tele-ICU programs. The doctor who's monitoring the patient remotely may not be any smarter than you are, but he's not exhausted. He isn't worrying about 10 other things. He is not emotionally connected to what's going on. So you get a much more objective assessment, which sometimes can save you from making really bad mistakes.
One question I wanted to ask as a follow-up to that, in the telementoring, and I apologize if you mentioned this earlier, do the participants ever record it to watch it again and again? Because again, if you're providing a lot of information, sometimes the repetitiveness and the ability to go back and see that again sometimes is helpful. Do you find your participants doing that?
Yeah, no, that's a great question. We do sometimes see them with their cameras and with their iPhones recording. We do have standard videos also that we share with them with the techniques that we're trying to reinforce. I wouldn't say they do it in a systematic way, but I think that's actually a good idea. So maybe something that we should incorporate.
Great.
As we look at telementoring, one, do we have any information now that by doing these kind of courses in a box actually carry over into patient care and safety? Does it make a difference? And two, there's Tim Donovan that pointed out to me from Storrs, he was in the Navy, saying that the recent simulation model for one of the air fighters was so good that they do the simulation. They don't need the simulation or somebody really working with them in the real plane. They get in the plane and they know how to fly it. Is our simulation good enough that we're going to be able to simulate and then have somebody go from a simulator and already be able to do the procedure?
So those are two great questions. Let me start with the second one first, and this was something that I actually did my thesis on. We did a randomized controlled trials comparing two groups of first-year residents in their first 2 months who, many of you may have seen virtual reality simulators. They simulate a cholecystectomy very well, and we basically randomized one group to doing the cholecystectomy, so the actual procedure laparoscopically, until they could do it as well as an expert on the virtual reality simulator. And the other group also did VR training, but they just did the basic tasks that weren't operation specific. And I wasn't part of the training. I was one of the surgeons that would then get the residents in the operating room after they'd been randomized. And so that's the analogy is to your fighter pilot that's trained in the simulator and then can go right on the plane. And they were good, but sometimes it was scary because they were too aggressive. They didn't, it just made me uncomfortable. They'd take the gallbladder and they were kind of, they were just pressuring the operation, and they didn't have the clinical judgment and the sense of the tissues and really all the things that it takes a long time to learn during surgery. So will we ever get there? It's possible, but we're not there yet. Now, the answer to our research question was that yes, they were better than the other group. They started at a much higher level, but they weren't at a surgeon's level, and I think they would still need several years. Your first question was, I've forgotten now. I'm sorry, Ray.
First question was, do we have any information that by learning on a box is actually transferable over into the clinical situation? Yeah,
so that's another very good question. It's almost like the holy grail of simulation research, to be able to show that training on a simulator translates to improved patient outcomes. There is some limited data to support this. The challenge is that our patients, especially in our context and in the world that we practice in, they do very well. The trainees are very closely supervised, and for the most part we have very, very good outcomes. So it is difficult to show improved patient outcomes. What studies have shown in cholecystectomy, for example, is that someone who's trained on a simulator can do the operation slightly faster, perhaps with slightly less blood loss. On an endoscopy simulator, the patient may have less pain. So there is some evidence out there, but we definitely need a lot more.
Just one of the experiences I could refer to from the University of Illinois Chicago, which is where I came from. Their dental program was using a simulator with a haptics device in a virtual reality setting, so they would look through a glass and actually be holding a haptics device and working on teeth, both for drilling and cleaning and things like that. And they had designed a very low-tech device, and the whole package was less than $5,000 for almost an entire dental course. And they were showing that by doing this, the students, when they went to the patients, were doing better and things like that. Now, there were all sorts of pieces, because it was just the teeth. If you slipped down into the gums, the simulator didn't react, but it was definitely an interesting way to watch them learn and carry those to the patients at the bedside, or the chair side in that case. So, does that mean I have 1 minute and I'm supposed to stop talking? Excellent. Any other questions? And you have less than a minute, so.
Oh, that's a tough one. My two questions/comments. One is that I think there's a big difference when you train a trainee who's a PGY1 versus training a trained surgeon who might already have a lot of open surgery experience, and you're training them to do laparoscopic work. And I think that the way we design, the simulators needs to reflect that. They already get how to touch tissues, but maybe can we just break those moves down into like what's important for a particular operation. I know Intuitive has done some of that with their robotics simulator, and so I think that some of our curricula needs to take that into account, who we're training. And then the other issue I think is important is to, instead of teaching the steps of an operation, to teach the nuances of, there's a gallbladder and there's a gallbladder and there's a gallbladder. And I remember, I'm not a general surgeon, but Netter used to have this page of all the different anatomic variations. And I think that's what's really important, is to use simulations to, normally you have to see hundreds of patients to see all of those tough cases. But if we can use simulation to train someone to know what to do in those cases, I think that's where the real power of it comes.
Yes, you used up the minute, so we're good? Okay, I'll behave and not continue on.
Thank you.
So thank you, everybody.